Thanks, George, and hi. It's really nice to see so many of you here today. As George says, I am a family physician. Where is this? Yeah. I am a family physician in Vancouver. I got a lot of material where I'm going to try to just update you on the 2015 CHEP guidelines and the changes that are relevant to blood pressure measurement and diagnosis. I'm hoping that by the end of this you'll understand all of these bullet points. I'm not going to read them, but hopefully you'll understand that we've asked and recommended that blood pressure measurement be improved so that we can better diagnose patients and better manage their health. I do have one commercial interest. I'll just put that up front. So what's new? For 2015, we had 4 main new recommendations. I'm not going to speak much about the third and the fourth. I'm not going to speak at all about the third and the fourth. They're being covered in other places. So I'm really just going to talk about the recommendations to measure blood pressure in the office or clinic using an electronic device. The word oscillometric just pertains to the actual mechanism of the device, and most of the electronic devices that you will ever see utilize this method. And then the other major recommendation is that the diagnosis of hypertension should be based on out-of-office measurements. There's a number of ways to take blood pressure measurement, as you know. I sort of like to look at them this way. In the office, you can either take blood pressure manually or automatically. Manually can be done via auscultation, which is the tried and true older method using either a mercury or aneroid sphygmomanometer. It requires a stethoscope. Or electronically. You can take a blood pressure in the office electronically, manually. I'll show you, we'll get into that in a second. The newer methods, new by now, it's been about 15 years, but I think new in that we're just going to focus a bit on automated office blood pressure today, so you'll understand why in a second. And then there's ambulatory blood pressure measurement and home. All methods of blood pressure assessment for the purposes of diagnosing hypertension should be done in a really organized protocol. Patients should be seated with their, well, what's happening? We're getting it? Oh yeah, with their back supported, their legs uncrossed, their feet flat on the floor, their arms supported so that the midpoint of the cuff is at the heart level. And this goes for all methods of measurement in office or home. The first recommendation, this is the wording, is that office blood pressure measurement using electronic oscillometric upper arm devices is preferred over auscultatory methods. The rationale behind this is that there are many studies now over the last several decades that have looked at all the errors associated with routine office blood pressure measurement. We all seem to commit the same errors, and despite multiple educational programs and knowledge transfer strategies, CHEP has tried for years to show people how to measure blood pressure carefully. These gaps continue to plague us. So that in the real world, and that's what we're talking about, is real world blood pressure measurement, the accuracy of manual blood pressure measurement is really affected by device factors, health practitioner factors, and patient factors. So things like conversation during blood pressure readings, only taking a single reading, no rest period, rapid deflation of the cuff, digit preference, and then obviously patient anxiety, which we'll get to in a second, and and then some issues around the devices. This has been quantified. A number of studies have shown that there really is a difference between routine clinical blood pressure measurement and the standardized blood pressure measurement that so many of our earlier guidelines and recommendations were based upon. A lot of all the early outcome studies were done using manual measurement, but the measurements were highly regulated and observed very carefully, so that in the real world now, what we're finding is there is a very significant difference between the real world measurements and what we think we're getting. So we have these two terms, and this is where I want to just spend a minute just to try to uncomplicate this a bit. OBPM and AOBP, and I just want to tell you a few of the similarities and differences. Obviously, both require the use of standardized measurement technique. Every method does. Positioning of the patient is the same, and upper arm cuffs are always preferred. We recommend the use of only validated devices. I'm not sure how many people understand that term, but validated devices, there are 2 or 3 international protocols now for device assessment so that you can actually measure and quantify differences between measurement techniques so that we can give a bit of a stamp of approval, and these really must be done independently and published in peer-reviewed journals. So that's the term validated devices, and I'll give you some references later on where you can find these things. But how do they differ is really the big point. Office blood pressure measurement is performed with the healthcare professional in the room with the patient. So it's really it's attended. AOBP is performed with the patient alone in the room, and multiple measurements are automatically done. So that's unattended. The first type, OBPM, needs a rest period. And that's a long tradition that we've advocated. But what we found for AOBP is that AOBP doesn't need that. Both types of measurements should include more than one reading. For OBPM, if you're in the room with the patient, to do an assessment properly, you really should do at least 3 readings, and the first one should be discarded. For AOBP, the average is done for you, and one of the devices even discards the first reading. So OBP, now that we've eliminated or trying to eliminate the auscultatory method, OBP, if you're going to be in the room with the patient, should be done with an electronic device, and you'll be pushing the button 3 times. With automated office blood pressure measurement, it's a little bit different. There are 2 there's 3 devices in 2 broad groups. As I said, 5 minutes of rest has been shown not to be necessary, but the patient should be alone in a room. With the BP-True was originally designed to do 6 readings at 1 or 2 minute intervals. The first reading is automatically discarded, and then the remaining 5 are averaged. With the Watch BP, which is by Microlife, or Omron 907, 3 readings are taken at 1 minute intervals. The machine has a 1 minute rest period programmed into it so that you push the button and leave the room, and then all 3 readings are averaged. Lots of evidence behind the value of AOBP. AOBP readings have been shown to be lower than routine office blood pressure measurement in a number of trials. AOBP is comparable to awake ABPM, so there's a lot of studies now in several countries, over 2,500 patients, showing that if you do AOBP properly as it's designed, the results will give you a reading, an average reading that is comparable to the mean awake ambulatory blood pressure, daytime ambulatory blood pressure. There's a strong correlation, obviously a much stronger correlation between AOBP and the awake ambulatory than there is for office blood pressure alone. So AOBP enables multiple readings automatically. It reduces the white coat effect. It's consistent from visit to visit and not affected by the setting. Studies have shown that it can be done in pharmacies, waiting rooms, etc. Importantly, the AOBP has a much stronger link to some of the surrogate markers of target organ damage, such as left ventricular mass index or CIMT. And finally, and this is really hot off the press, just published last month by a Canadian group, AOBP is predictive of cardiovascular risk, which is what we anticipated, but needed time for these trials to be done. So just a little preview, if I may. This is a draft, hasn't been approved yet, but you'll hear about it tomorrow, so don't tell anybody, please. So what we did based on the cumulative totality of evidence yesterday at CHEP was we made the recommendation that AOBP becomes the preferred method of performing in-office blood pressure measurement. Just a couple of practical points about AOBP. It does take time. It's best done in a practice with 2 or more examination rooms, a dedicated vital signs monitoring area, or even an area of the waiting room that's semi-private. And there's lots of papers and studies that have shown all these places are valid. The devices do cost a bit of money. I know your old Mercury device or Android device doesn't owe you anything anymore, but really, if you don't use an automated device, it's time. There are many other practical issues, but I can tell you that if you do have a setup somewhat like this, it really actually helps you save time, because if you're going to take 3 readings sitting in a room, then you might as well let a machine do it for you. It's going to do it accurately, reproducibly, and reliably. It just makes sense. So I'm going to shift gears, if that's okay, and maybe if anyone has questions, you can maybe keep them for later. Because the second major recommendation for 2015 was this. If on the first, it's a bit complicated, I'm sorry, but that's because we still have two measures in the office. But if at the first visit, the office visit is elevated, then out-of-office measurements should be performed before the second visit. And in our algorithm, this is the relevant portion of our algorithm, but this is what that translates to. So if you identify a patient with an elevated blood pressure reading, whether you've seen it in the office or at home, or they come in and report it from a pharmacy reading, then you should have really an evaluation visit that assesses their blood pressure measurement, assesses their blood pressure, and also looks at some of the other markers that we'd want. So a physical exam and starting to order some of the diagnostic tests. If the blood pressure is highly elevated, over 180 systolic, over 110 diastolic, you can safely make a diagnosis of hypertension and treat that accordingly. But in the mid-range, we really want people to understand that it's important to do out-of-office blood pressure measurement. And this is because blood pressure is not as simple as when we would like it to be, and There are more than two categories of blood pressure status. There's not just normal tension and true hypertension, but the two categories that make this all confusing are the white coat hypertension and masked. So I'm not going to spend any time talking about masked hypertension today because CHEP is going to tackle that for next year, we think. But white coat hypertension is a very important piece of this. White coat hypertension, about 25% of those with elevated office blood pressure readings have white coat hypertension. So by definition, obviously, white coat hypertension is where the office blood pressure reading's elevated, but outside the office, it's normal. The reason it's important to identify these people is because many studies have shown that patients with white coat hypertension do not have increased cardiovascular risk. That doesn't mean we shouldn't watch those people and assess them regularly, but they do not have elevated risk. Many years ago in the 80s, this very elegant study showed the alerting effect. This is done, I don't think we could do such a study now, but this is done with an intra-arterial line, just assessing the impact of either a nurse walking in the room, so that's the elevation of blood pressure when the nurse walks in, and then over time how it settles, and obviously even higher with a doctor walking in the room. And so that's what's happening to your patients, and that's why this is an important issue. There aren't any pathognomonic diagnostic features of patients with white coat hypertension. They don't really walk around with a name tag. So you have to go looking for them. And obviously, it's a diverse crowd. 25% of all patients with an elevated blood pressure reading. So how do you assess them? We assess them in a couple of ways. You can use a 24-hour ambulatory blood pressure measurement. I hope most of you have seen this or are familiar. So this is a cuff with some tubing that goes under your clothes, and you wear it attached to a little recorder for 24 hours. A good report will give you all the readings. It'll show you the readings graphically. It will give you the day and night periods and what those thresholds should be for turning them red or black. And then it'll give you the averages for the awake, the asleep, and 24 hours. And finally, it'll tell you if they're dipping or not. And that's a term relating to how the blood pressure normally dips at night by at least 10%, 10 to 20%. The other method, of course, of assessing blood pressure out of the office is at home, and Hypertension Canada has a very nice description in our recommendations and in all of our materials for patients and for healthcare professionals that a home blood pressure series is 2 readings in the morning, 2 readings at night, about a minute apart for a week. The first day's readings are discarded, and then the rest are averaged. There's a whole literature on home blood pressure measurements and how they're done, how well they're done, or how not well they're done. But it is an important measure, and we do rely on this. But the evidence has shown that ABPM has better predictive ability than office blood pressure measurement, and it's the recommended out-of-office measurement method. Home blood pressure measurement also has better predictive ability than OBPM, and it's recommended if ABPM is not tolerated or available, or if patients just won't wear it. Of course, the reason for doing it is that it identifies patients with white coat hypertension. So the recommendation says exactly that. ABPM is a recommended out-of-office measurement method. patients can be diagnosed with hypertension according to those thresholds that are published. Home blood pressure measurement is recommended if it's not tolerated, if ABPM is not tolerated, not available, or due to patient preference. And here's just some of the evidence showing you the correlation with risk, just showing you that ABPM is just a little stronger correlated with LVH and microalbuminuria than home. And this is just a sample of many, 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 many studies. And finally, the last part of that recommendation is that if out-of-office blood pressure average is not elevated, then we should be labeling patients as white coat hypertension, and pharmacologic treatment should not be instituted. Now, of course, that doesn't mean you shouldn't be doing all the other recommendations, all the other therapeutic recommendations in lifestyle improvement and management. And the reason behind that is that there is some evidence that shows that if you do take patients with white coat hypertension, treatment may lower the office reading, but it actually doesn't lower their overall readings. And then, of course, unnecessary treatment can lead to partial reduction in the white coat effect, but the risk is the same because they were already low risk. And then there's a few other associations. So here's the full diagnostic algorithm for 2015. As I showed you, elevated readings either seen in the office, home, or pharmacy, a first evaluation visit. If they're stage 3 hypertension or higher, then you should diagnose it right away and do something. If not, then out-of-office measurements should be done. And the key here is that the out-of-office measurements trump the office measurements. So it's important to get past that mindset. Then there's some follow-up recommendations, which are just for another topic. Now, we did keep in dots the old methodology of multiple office visits, up to 4 or 5 visits before you make the diagnosis of hypertension. But we're hoping that this will fade into the past. That's all I'm going to say today. I just want to tell you that Hypertension Canada does have an interdisciplinary online course that you're more than welcome to have a look at our website. It's about a 15.5-hour course and divided into 5 sections. And you do get certification. Thank you very much.